I pronounced her dead, and the worst part is that I followed every rule while I did it. My name is Dr. Natalie Rowland. I am 46 years old, and until recently, I worked as an attending physician in hospice and palliative care. I spent most of my adult life inside hospitals before I moved into hospice work, and I believed that transition meant fewer surprises. Hospitals are chaotic. Hospice is supposed to be predictable. People do not come to hospice to recover. They come because recovery is no longer on the table. That distinction mattered to me. In a hospital, doctors chase numbers. In hospice, doctors protect process, pain control, comfort, dignity, documentation. When death comes, it should arrive quietly, without drama, and without unanswered questions. I was very good at that job. That is not arrogance, it is repetition. After enough years, patterns settle in your bones. I worked at Willow Crest Hospice Center on the outskirts of Columbus, Ohio. It was attached to a larger hospital network, which meant our policies were conservative and our paperwork was aggressive. Everything required a signature. Everything had a timestamp. Families appreciated that. Administrators loved it. So did I. Clear rules are comforting when your entire career revolves around people dying on schedule. I had been doing hospice work for almost a decade when this happened. Before that, I was a hospitalist. I handled codes, rapid responses, ICU handoffs, and conversations that start with, "We did everything we could." By the time I moved into hospice, I thought I had already seen the worst medicine had to offer. Hospice felt slower, quieter, more humane. The case I am about to describe did not look unusual at intake. That is important. Nothing about it triggered alarms. No dramatic arrival, no frantic family, no late-night phone call from the emergency department. On paper, it was clean. Too clean, if I am being honest, but that realization came later. If you are still watching at this point, I will ask one thing. Leave a comment when you finish this video. Doctors and nurses rarely talk about cases like this out loud, and I want to know if you have ever seen something that didn't fit the rules either. And if you haven't already subscribed to the channel, stories like this don't come from textbooks. They come from people who stayed quiet for a long time. Hospice teaches you how to be comfortable with endings. You learn the signs, the breathing patterns, the skin changes, the way a room feels when a body is preparing to stop. There is nothing mystical about it. It is physiology slowing down in predictable steps. That predictability is the foundation of hospice care. Without it, we would just be guessing. I trusted that predictability. I trusted it the same way I trusted medication dosages or lab reference ranges. When I pronounced a patient dead, I did it because I had confirmed the absence of circulation, respiration, and responsiveness. I documented the time. I signed the form. I spoke the words out loud. It was not ceremonial. It was procedural. On the night this began, I was covering the overnight shift. That alone was not unusual. I preferred nights, fewer meetings, fewer administrators, just nurses, patients, and quiet hallways. The kind of quiet that lets you hear your own thoughts whether you want to or not. I remember thinking it was going to be a routine shift. No new admissions, no unstable patients. I even joked with one of the nurses that it might be a paperwork night, which is hospice slang for boredom. That joke did not age well. What matters is this. When I walked into that room later, I was not nervous. I was not rushed. I was not distracted. I did exactly what my training told me to do. I checked, I waited, I checked again. And when I said the words time of death, I believed them. That belief is what this case took from me. Because once you realize that following every rule can still lead you somewhere you don't understand, the rules stop feeling solid. They start to feel like habits. And habits are easy to trust until the moment they fail you. I did not know any of that yet. At that moment, all I knew was that I had a quiet room, a patient who met every criterion, and a job I had done thousands of times before. I left the room thinking the night would continue the way hospice nights always do, slow and uneventful, with nothing waiting for me except charting and coffee that tasted like burnt regret. I was wrong about that, but not in the way people expect. Nothing dramatic happened right away. No alarms, no shouting, no sudden emergency. The first sign that something was off did not announce itself. It arrived the way real problems usually do in medicine, quietly and with just enough uncertainty that you can talk yourself out of taking it seriously. I had no idea that the confidence I carried into that shift would not survive the next hour, or that the systems I relied on would offer no guidance once they stopped agreeing with each other. At the time, I was still thinking like a hospice doctor who believed the hardest part of the job was helping families accept what the body had already decided. I hadn't yet learned that sometimes the body doesn't cooperate with that decision, and when it doesn't, there is no protocol that tells you how to feel about it. I walked back to the nurses' station, opened the chart, and began typing notes I had written 1,000 times before, unaware that I was documenting the last moment when everything still made sense to me. Those final, ordinary sentences would soon feel strangely dishonest, even though every word was accurate. I kept typing until the cursor blinked at the end of the sentence, waiting for me to move on. The nurses' station was quiet in the way it usually was after midnight. Phones were docked, monitors glowed softly. Someone had left a half-empty cup of coffee near the printer already cold. I signed the pronouncement note, added the time, and closed the chart. From a systems perspective, the case was finished. That mattered more than people like to admit. Hospice care is built around that idea. When death is expected, everything becomes procedural. The work is not about saving lives, it is about managing endings. Hospitals are reactive, hospice is anticipatory. You are always a few steps ahead, preparing for what everyone knows is coming. At Willow Crest, the system was tight. We were part of a large hospital network, which meant our policies mirrored inpatient standards, even though our mission was different. Every patient had a documented trajectory. Every decline was logged. Every medication change required justification. When death occurred, there was a clear sequence of actions that followed. Nurses verified, a physician pronounced, paperwork moved forward, the body was prepared, the family was notified. Nothing about it was supposed to be ambiguous. That structure was intentional. Ambiguity is the enemy in end-of-life care. Families want certainty even when the outcome is painful. Staff need clarity to function. Administrators need documentation that will survive audits, legal review, and the occasional hostile relative who insists something was missed. Hospice systems exist to make death legible. Doctors and nurses rely on that legibility more than we like to acknowledge. When a patient stops breathing and has no pulse, that is not just a biological event. It is a signal to the system that a process can begin. Beds are reassigned. Medications are discontinued. Equipment is cleaned. Staff emotionally reset and move on to the next patient who still needs attention. That night, everything was behaving the way it always did. The nurse on duty had already begun post-mortem care in the room. Another nurse was updating the shift log. I could hear the low hum of the HVAC system, cycling a sound so constant that you stop noticing it unless it stops. Nothing in the environment suggested disruption. Hospice nurses are exceptionally good at pattern recognition. They notice subtle changes long before machines do. A difference in breathing, a change in skin tone, a quiet that feels heavier than usual. They also understand the system. They know when to escalate and when not to. Most of the time, they do not call a physician unless something is truly off. That is why the absence of urgency mattered. No one was panicking. No one was running. The nurse who had just been in the room walked back to the station at a normal pace. She did not look alarmed. She looked uncertain, which is a very different thing. Uncertainty is uncomfortable in hospice. It has nowhere to go. There is no code team to call, no crash cart to roll in, no ICU bed to request. When something does not fit, it tends to sit there waiting for someone to decide what it is allowed to be. From an administrative standpoint, hospice deaths are remarkably clean. They are rarely reviewed in detail. There are no mortality conferences, no root cause analyses. As long as the documentation is complete and the pronouncement follows policy, the case disappears into the archive. That invisibility is part of the job's appeal. I trusted that invisibility. It meant that once I closed a chart, the system would carry the weight forward. My responsibility ended at accuracy. After that, hospice took over. The patient in that room had been assessed multiple times before that night. Her condition was not new. Her prognosis was not in question. She had met hospice criteria weeks earlier, and nothing about her clinical course suggested deviation. The system had accepted her as terminal without hesitation. That acceptance matters. Hospice does not take patients lightly. There are eligibility requirements tied to diagnoses, functional decline, and expected survival. Physicians sign off, medical directors review, insurance approvals follow. By the time someone reaches a hospice bed, several layers of medical authority have already agreed that death is not just likely, but imminent. That agreement gives hospice staff a kind of grim confidence. You are not guessing. You are executing a plan that has been reviewed and approved. When the end arrives, it should confirm what the system already knows. I glanced back at the chart, scanning the timeline. Vital signs from earlier that evening were unremarkable for someone at that stage. Low blood pressure, shallow respirations, decreased responsiveness, all expected, all documented. There was nothing in the record that suggested instability beyond what hospice anticipates. The system had done its job. The patient had done what the system expected of her. That alignment is the backbone of hospice work. I stood up from the station and took a few steps down the hallway, more out of habit than concern. Night rounds are often an excuse to move to keep your body awake when your mind is drifting. The hallway lights were dimmed, motion sensors set to respond only when necessary. Doors were closed. The building felt settled. Hospice facilities are designed to feel less clinical than hospitals, but the infrastructure underneath is the same. Oxygen lines run behind the walls. Call buttons connect to central panels. Monitoring equipment is simplified, not eliminated. The system is always present, even when it tries to be discreet. That discretion can be misleading. It gives the impression that things are gentler than they are. In reality, the same rules apply. Biology still follows its course. Documentation still matters. Legal definitions still determine what happens next. As I walked, I thought about how often doctors say that hospice is where medicine becomes human again. There is some truth to that, but it is not the whole story. Hospice is also where medicine becomes quiet. And in that quiet, systems become louder. Every decision in hospice is framed by policy, pain management protocols, medication limits, pronouncement guidelines, transfer rules. When something falls outside those boundaries, there is no backup plan. There is only the uncomfortable space between what is happening and what is supposed to happen. I reached the end of the hallway and paused, listening. The HVAC hum was steady. No alarms, no raised voices. Everything sounded exactly as it should. The building itself seemed to agree that the night was under control. That sense of control is fragile. It depends on the assumption that bodies behave predictably once they begin shutting down. It depends on the idea that death is a process we understand well enough to manage without surprises. Hospice systems are built on that assumption. I believed in that assumption without question. It made my work possible. It made nights like this manageable. It allowed me to trust that once a death was pronounced, the story was complete. I had no reason to think otherwise as I turned back toward the nurses' station, still operating under the quiet confidence that comes from working inside a system that rarely admits when it does not know what to do. The nurse was standing by the counter when I came back, scrolling through the patient list with the kind of focus people use when they are trying to confirm something they already know. Her name was Eleanor Vance, 34 years old. Even after years in hospice, that number still felt wrong. Hospice patients are usually decades older. When someone that young ends up on our service, it means the system has already failed them somewhere upstream. Trauma, cancer, catastrophic neurologic injury. There are only a few paths that lead a person in their 30s to hospice, and none of them are subtle. Eleanor had been admitted 3 weeks earlier after an anoxic brain injury caused by an overdose. She had been found unresponsive, resuscitated in the field, stabilized in the hospital, and eventually transferred out when it became clear that meaningful neurologic recovery was not going to happen. Imaging showed extensive damage. Exams were consistent. She never regained awareness. By the time she arrived at Willow Crest, every specialty that needed to weigh in already had. Her paperwork was immaculate. Do not resuscitate, order signed, healthcare proxy documented, hospice eligibility confirmed, insurance approved. Medical director reviewed the case personally because of her age. Nothing had been rushed. Nothing had been overlooked. From a clinical standpoint, she was exactly where she belonged, and yet from the moment I first met her, she felt out of place. It wasn't anything measurable. Her vitals followed the expected pattern. Her labs had already done what labs do in cases like hers, slowly drifting away from normal before losing relevance entirely. She did not respond to voice or touch. She did not track with her eyes. Neurology had been clear. There was no meaningful brain activity to work with, but she did not look like most hospice patients. Her body had not wasted away. Her skin tone was even. Her muscles were still firm. If you didn't know her history, you might have mistaken her for someone sleeping deeply after a long illness. Nurses noticed that too, though no one said it out loud. In hospice, you learn quickly which observations are useful and which ones just make things harder. Her room was kept simple. No family photos, no flowers, no personal items beyond a small overnight bag that had arrived with her and never been opened. Family visits were rare. When they did come, they stayed briefly, spoke quietly, and left with visible relief. That reaction always sits poorly with staff, but it is more common than people admit. Nurses provided routine care, turning, mouth care, skin checks, comfort medications as ordered. Everything was done correctly. There were no signs of distress, no agitation, no labored breathing beyond what we expect in advanced neurologic injury. She existed in that suspended hospice state where time stretches and meaning becomes abstract. From a systems perspective, Eleanor was stable. Stable did not mean improving. It meant predictable. Predictable patients are easier to care for, especially at night. They let the unit breathe. On the evening she died, nothing about her condition suggested urgency. Her blood pressure had been low but steady. Her respirations were shallow but consistent. Oxygen had been discontinued days earlier because it was no longer providing benefit. Comfort measures were in place. The nurses had done their rounds and noted nothing new. When I went into her room to assess her, it felt routine. I checked for responsiveness. None. I listened for breath sounds. Absent. I palpated for a pulse. Nothing appreciable. I waited. I checked again. Still nothing. Her pupils were fixed, not reacting to light. Her chest was still. Pronouncing death is not dramatic. It is quiet and clinical. You do not rush it, but you do not linger either. You confirm what your training tells you to confirm, and then you move on. I documented the time, spoke the words, and stepped back. There was no emotional weight to that moment. That is not callousness. It is survival. Hospice physicians cannot afford to attach significance to every death or the work becomes impossible. Eleanor's death felt sad in the abstract, mostly because of her age, but not unusual. After the pronouncement, the nurses began post-mortem care. They removed monitoring leads. They adjusted the bed. They prepared her body the way they had done hundreds of times before. Everything proceeded exactly as it should have. The nurse standing at the counter now had been the one in the room. She wasn't alarmed. She wasn't panicked. She was doing what hospice nurses do when something doesn't fit neatly into a box. She was double-checking. I might be overthinking it, she said, not looking up from the screen. That sentence alone was enough to make me pause. Hospice nurses do not overthink without reason. They are trained to trust patterns, and patterns had taught her that something was slightly off. I asked her what she was seeing. She hesitated, choosing her words carefully. That hesitation mattered more than the words themselves. She just doesn't look like the others usually do at this point, she said. That was vague enough to be meaningless, but specific enough to register. I asked her to clarify, and she shrugged, clearly uncomfortable with how subjective it sounded. She doesn't feel different, the nurse added quickly, as if trying to correct herself. It's just that I expected more change by now. More change. That was an interesting way to put it. I glanced at the chart again, scanning timestamps. It had been just over half an hour since the pronouncement. That is not long in hospice time. Bodies do not transform instantly. Rigor mortis takes time. Temperature changes are gradual. Nurses know this. That is why her comments stood out. I asked if she had noticed any movement, any sounds, any reflexive responses. She shook her head. No, nothing like that. It's probably nothing, she said, though she did not sound convinced. I told her I would take another look. Not because policy required it, but because ignoring uncertainty is how mistakes get made. Even in hospice, especially in hospice, you listen when a nurse says something doesn't feel right. As I walked back toward Eleanor's room, I tried to frame the situation rationally. Young patient, good muscle mass, short interval since death, all reasonable explanations for why the expected changes might not be obvious yet. There was no reason to assume anything abnormal. Still, there was a faint resistance in my chest, the kind you feel when your brain is already preparing to adjust its expectations. I pushed it aside. Medicine rewards discipline, not intuition. The door to her room was partially closed. Light from the hallway spilled in across the floor, stopping just short of the bed. I reached for the handle, fully expecting to confirm what the chart already said, unaware that the second look was about to shift the entire frame through which I understood my work. I pushed the door open with 2 fingers and stepped inside, letting it close behind me without a sound. The room looked the way it had when I left it. The bed was flat. The sheets were clean and folded back neatly at the shoulders. The overhead light was dimmed to the lowest setting enough to see without turning the space clinical again. Eleanor lay exactly where she had been, her head angled slightly to the left. Her mouth relaxed, her eyes closed. If I had not been the one to pronounce her, I would have assumed she was sleeping. I stood still for a moment, not out of fear, but out of habit. You learn to pause before touching a body, to let your senses adjust. I watched her chest. There was no obvious rise or fall. I listened. The room was quiet, except for the faint background noise of the building. I moved closer to the bed and placed my fingers on the side of her neck where the carotid artery should have been easy to find if it was there. I waited longer than I had before. Nothing. I shifted slightly and tried again. Still nothing that could be called a pulse. I checked her wrist out of routine. Same result, no organized circulation. I leaned in and watched her face, looking for any subtle movement around the mouth or nostrils. There was nothing deliberate, no effort, no response to sound. I shined my penlight into her eyes. The pupils were fixed and unreactive, exactly as they had been earlier. I waited a few seconds and repeated the exam. No change. This was consistent. Everything I was seeing matched the documentation. From a clinical standpoint, the pronouncement still stood. I straightened up and let out a slow breath. This was the moment where uncertainty usually resolves itself. Most of the time, a second look reassures you that the system is functioning as intended. I was already preparing to walk back to the nurse's station and tell the nurse she was right about one thing, that this was probably nothing. Then I noticed her abdomen. It wasn't movement in the way people imagine when they hear that word. There was no sudden gasp, no dramatic rise of the chest. What I saw was slower, subtler. A faint outward motion low in the abdomen, followed by a pause, then a gentle release. I stood there long enough to convince myself it could be coincidence. Bodies shift, muscles relax, air escapes. Hospice teaches you not to overinterpret isolated observations. I watched again, the same motion repeated, almost identical in timing. Slow expansion, brief stillness, release. I placed my hand lightly on her abdomen just above the sheet. The skin was cool, not cold. Under my palm, I felt a shallow movement, barely perceptible, like the echo of a breath rather than the thing itself. I lifted my hand and stepped back, giving myself space to think. My first assumption was reflexive movement. The nervous system can do strange things at the end. There are documented cases of spinal reflexes persisting briefly after death. None of that would have been alarming on its own. What made this different was the pattern. Reflexes are irregular. This wasn't. The timing was steady, not rapid, not labored, just slow enough to make you question whether it was really happening. I checked my watch without realizing I was doing it, counting 1, 2, 3, 4, 5, 6. The movement happened again. I leaned closer, careful not to touch her this time. I listened, holding my breath so I wouldn't confuse my own breathing with what I was hearing. At first there was nothing, then faintly a soft sound, not a gasp, not a sigh, just the slightest movement of air. My stomach tightened in a way that had nothing to do with fear. It was recognition. Something was occurring that did not have an immediate explanation. I went through the checklist in my head automatically. Agonal respirations can occur near death, but they are irregular and forceful. This was neither. Post-mortem gas release can mimic breathing, but it doesn't repeat with this consistency. Equipment malfunction wasn't relevant. There was nothing attached to her that could create the illusion of movement. I placed the stethoscope on her chest, listening carefully. There were no heart sounds. That part had not changed. I moved the diaphragm lower, listening over the lung fields. I did not hear air moving the way I would in a living patient, but I did hear something faint like a whisper of sound that didn't fully register as breath. I stepped back again and rubbed my face, suddenly aware of how awake I felt. Fatigue can play tricks on perception, especially during night shifts. I told myself that was the most likely explanation. I needed another set of eyes. I stepped out of the room and motioned to the nurse at the station. She followed me back without speaking, her expression neutral but attentive. She stood where I had stood and watched. "I might be imagining this," I said, choosing my words carefully. "Tell me what you see." She didn't answer right away. She watched Eleanor's abdomen, her brow tightening slightly. After a few seconds, she tilted her head as if trying to catch a sound at a distance. "I see it," she said finally. "It's not much, but it's there." I asked her to count with me. We watched together, silently counting the seconds between movements. The timing matched mine. That mattered more than anything else. I asked her to check for a pulse. She did, using the same method she had used dozens of times that night. She shook her head. "No pulse," she said. "Nothing organized." I asked her to listen. She placed the stethoscope on Eleanor's chest, then lower, mirroring my exam. She straightened slowly, her mouth pressed into a thin line. "It doesn't sound like breathing," she said, "but it doesn't sound like nothing either." That was the problem. Medicine is comfortable with extremes, alive or dead, present or absent. This sat in between, and there was no language for it. I asked her to check the oxygen saturation with a portable monitor, not because I expected a meaningful number, but because data can ground you when your instincts start to drift. She clipped the probe onto Eleanor's finger and waited for it to register. The screen flickered, searching for a signal. For a moment, I expected it to fail entirely. Instead, a number appeared. Not high, not normal, but not zero either. We looked at each other, both of us, careful not to say what we were thinking. "This doesn't change the pronouncement," I said, more to myself than to her. "No," the nurse agreed. "It doesn't," but neither of us moved to leave the room. I took the pulse oximeter from the nurse and repositioned it myself, more out of reflex than disbelief. Cheap monitors can give false readings. Cold fingers confuse sensors. Poor perfusion produces nonsense numbers. Every clinician learns early not to trust a single data point, especially one that doesn't match the clinical picture. I adjusted the probe, waited for it to settle, and watched the screen refresh. The number dropped, then climbed again, hovering in a range that made no sense for someone with no detectable circulation. Not good, not normal, but not absent. I removed the probe and set it aside. The reading alone meant nothing. What mattered was that it had registered at all. I checked Eleanor's skin again, this time with intention. Her extremities were cool as expected, but not mottled. There was no purple pooling in dependent areas. Her color was pale but even. That struck me as unusual, though I didn't say it out loud. Post-mortem changes don't follow a script, but they usually leave fingerprints. This hadn't yet. I asked the nurse to bring in the portable blood pressure cuff, even though I already knew what it would show. The cuff inflated, tightened, then deflated without finding anything meaningful. No surprise there. Blood pressure requires flow. We weren't seeing that. What we were seeing was something else. The abdominal movement continued, slow, consistent, just enough to demand attention. I watched Eleanor's chest and abdomen together, now trying to understand the mechanics. The chest remained still. The movement was lower, originating near the diaphragm. It wasn't strong enough to inflate the lungs in any obvious way, but it wasn't random either. I placed my hand lightly against her lower ribs and felt it again. A shallow contraction. Release, pause. From a physiological standpoint, there were explanations that almost worked. Residual neural activity, spinal reflexes, automatic muscle firing, each of those could account for brief or irregular movement. None of them explained persistence with rhythm. I checked the clock on the wall. We had been in the room for several minutes now. The pattern hadn't changed. The nurse shifted her weight from one foot to the other, a small sign of discomfort. Nurses live in the space between observation and action. They know when to escalate and when to wait. This sat uncomfortably in the middle. "Do you want me to call anyone?" she asked. The question was reasonable. It was also complicated. Who do you call when something doesn't violate a protocol but also doesn't fit inside one? I shook my head. Not yet. There was no emergency to respond to, no intervention indicated. From a legal standpoint, the patient had been pronounced dead. That status carries weight. You don't undo it lightly. Instead, I asked the nurse to bring the bedside glucose monitor. It was an odd request in this context, but glucose is a simple marker. In a truly dead body, levels drift quickly and unpredictably. In living tissue, they behave differently. She returned a moment later and performed the check with practiced efficiency. The number appeared on the screen, not elevated, not critically low, within a range that suggested residual metabolic activity rather than chaos. We didn't comment on it right away. Saying things out loud gives them power. We both understood that the more data we collected, the harder it would be to dismiss what we were seeing as artifact. I asked her to check Eleanor's temperature with a tympanic thermometer. Again, not because I expected clarity, but because I needed to know if the body was cooling the way it should. The reading came back slightly below normal, but not falling rapidly. "That's not what I'd expect," the nurse said quietly. "Neither would I. After death, temperature decline follows a fairly predictable curve influenced by environment, body mass, and clothing. Eleanor's room was cool. She was uncovered. She should have been losing heat steadily. Instead, she seemed to be holding on. I felt a tightening behind my eyes, not panic, but focus. This was the moment where medicine demands discipline. You gather information. You resist interpretation. You avoid dramatic conclusions. You document what you see, not what you fear. I asked the nurse to bring in the limited bedside EEG unit we kept for screening purposes. It wasn't a full neurologic study, but it could detect gross electrical activity. If there was anything resembling organized brain function, it would show at least something. The electrodes were placed carefully. The screen flickered, then settled into a flat, unremarkable trace. No meaningful activity, no surprise. Eleanor's neurologic status had been clear for weeks. That result mattered. It eliminated one of the most tempting explanations. This was not delayed recovery. This was not covert consciousness. Whatever was happening, it was not being directed by the brain. I stepped back and crossed my arms, forcing myself to slow down. The room felt different now, not ominous, just heavier. The nurse was watching me, reading my reaction the way nurses do. They look to physicians not for answers, but for cues. Calm or alarm, confidence or doubt. I kept my voice steady. "We're not changing her status," I said. "She's still deceased by every standard that matters." The words sounded correct. They just didn't feel sufficient. The nurse nodded, accepting the statement without argument. Hospice nurses understand gray areas better than most. They work in them daily. Still, her eyes kept drifting back to Eleanor's abdomen. We stood there for several more minutes observing. The movement did not stop. It did not increase either. It simply persisted, indifferent to our presence. I considered calling the medical director, but hesitated, not because I was afraid of being wrong, but because I wasn't sure what I would say. The body is doing something it shouldn't is not a clinical complaint. It's a problem without a destination. I considered the hospital, then dismissed it just as quickly. There was no indication for transfer, no intervention to offer. Sending a legally deceased patient to the emergency department because of unexplained diaphragmatic movement would raise more questions than it answered. The system is not built for edge cases like this. It demands clear categories: alive, dead, treat, do not treat. Eleanor occupied none of those cleanly. I asked the nurse to stay with me a little longer. She agreed without hesitation. We watched together, counting breaths that didn't quite qualify as breaths, listening for sounds that didn't quite qualify as breathing. At some point, the nurse spoke again, her voice low. "It feels like her body didn't get the message," she said. The phrasing was imprecise, but it captured something important. Bodies don't read charts. They don't know when paperwork has been completed. They follow biology, not policy. I didn't respond right away. I was thinking about how often medicine assumes compliance from the human body. How much of our confidence rests on the idea that physiology will behave within defined limits. I realized then that we were no longer observing a dying process. That phase had already passed. What we were seeing now was something else, something that existed outside the timelines we were trained to recognize. I checked the time again. The movement continued steady and unbothered. The room remained quiet. No alarms, no escalation, just two clinicians standing beside a body that refused to conform to expectations. Finally, I made a decision. Not a dramatic one, but a necessary one. I told the nurse to document exactly what we were observing, using neutral language, without interpretation. No conclusions, no speculation, just facts. She nodded and stepped out to retrieve the workstation, leaving me alone with Eleanor for the first time since the movement began. I stood there listening, watching, aware that whatever this was, it was not going to resolve itself quickly, and that the longer it persisted, the less useful our existing frameworks would become. I stayed by the bed while the nurse wheeled the workstation back into the room, the screen lighting up the wall with a pale glow. Documentation forces discipline. It slows you down and makes you choose words carefully. That was exactly what we needed. If this was going to turn into something larger, the record had to reflect observation, not reaction. I dictated findings out loud, while the nurse typed, both of us sticking to what could be seen, heard, or measured. Shallow diaphragmatic movement observed. Rate approximately 4 to 6 per minute. No organized cardiac rhythm detected by palpation or auscultation. No purposeful neurological response. Oxygen saturation intermittently registering at low but present levels on portable monitor. Tympanic temperature mildly reduced but not declining at expected postmortem rate. Each sentence felt like a small act of resistance against panic. I asked the nurse to draw a bedside blood gas using the point-of-care analyzer we kept for symptom management. It wasn't standard after death, but nothing about this was standard anymore. Blood gas values don't tell stories. They give you numbers. Numbers are grounding. The sample took longer than usual to collect. There was no obvious venous return, but there was enough to work with. When the analyzer finished, the results printed on a narrow strip of paper. I scanned them quickly, then more slowly. The pH was not acidotic. The carbon dioxide was elevated, but not catastrophically so. Oxygen levels were low, but present. Lactate was not spiking. These were not the values of a system in freefall. The nurse leaned in to look, her expression tightening. "That's not what I expected," she said. "It's not what I expected either," I replied. "In a dead body, metabolic waste accumulates quickly. Without circulation and respiration, chemistry unravels. That unraveling leaves signatures. We weren't seeing them yet." I asked her to repeat the glucose check. The value was nearly identical to the first, stable as if something was maintaining equilibrium at a minimal level, not thriving, not collapsing, just holding. I felt a pressure building behind my sternum. Not fear exactly, but the sensation you get when the ground under a familiar idea starts to soften. Medicine depends on thresholds. Above this number, below that one. Alive, dying, dead. Eleanor's numbers hovered in the margins, refusing to cross cleanly into any category. I called the medical director, Dr. Samuel Price, and asked him to come in. I kept my explanation brief. Unusual postmortem findings, persistent diaphragmatic activity, incongruent bedside labs. He didn't ask many questions. His pause before responding told me enough. "I'll be there in 20 minutes, he said. While we waited, I asked the nurse to notify the charge nurse and the on-call administrator, not because I wanted to escalate emotionally, but because systems don't like surprises. If this extended beyond the room, leadership needed to know it existed. More staff drifted in, quietly drawn by the unusual documentation request. A respiratory therapist stood at the doorway listening. Another nurse watched from the hall. No one spoke loudly. This wasn't curiosity. It was recognition that something was happening without a label. I repeated the exam again methodically. Pupils unchanged, no corneal reflex, no response to painful stimulus. The abdominal movement persisted steady and indifferent. The chest remained mostly still. Lung sounds were faint and inconsistent, not the clear airflow of normal respiration, but not silence either. I had the respiratory therapist listen as well. She shook her head slowly. "It's like the lungs are being pulled, not filled," she said. "There's movement, but it's not effective." That distinction mattered. Whatever was happening, it wasn't sustaining life in the way we define it. There was no evidence of meaningful gas exchange at a level that could support consciousness or recovery. This was not life returning. It was something else continuing. Dr. Price arrived and took in the scene without comment. He reviewed the chart, examined Eleanor, listened, watched, and then asked us to repeat the observations from the beginning. He was careful with his language, just as we had been. He studied the blood gas results and frowned. "These values should not look like this," he said. "Not after this amount of time." He checked the temperature himself, then the pulse points. Nothing. He stood back, hands on his hips, eyes fixed on Eleanor's abdomen. "This isn't recovery," he said finally, "and it's not artifact." That was the closest thing to validation I could have asked for. We discussed possible explanations, discarding them one by one. Residual brainstem function. Unlikely, given the EEG and exam. Delayed agonal breathing. Too regular, too prolonged. Equipment malfunction. The findings were consistent across devices and observers. Dr. Price asked the question none of us wanted to voice. Is there any scenario where she could still be alive in a way that matters? We all knew the answer. No, there was no pathway from this state back to consciousness. No intervention to reverse weeks of neurologic injury. Whatever was happening did not represent survivable physiology. And yet the respiratory therapist said quietly, her body hasn't shut down. That was the core problem. Hospice is built around guiding the shutdown process, not managing its refusal. Dr. Price called for an ethics consult, not because we were facing a decision, but because the presence of ethics signals seriousness. It creates a record that says this case was recognized as unusual and handled with care. The administrator arrived next, followed by someone from risk management. They asked careful questions, all focused on documentation and liability. Had the pronouncement been appropriate? Yes. Were comfort measures in place? Yes. Was there any intervention being withheld that should be provided? No. From a legal standpoint, the case was clean. That did nothing to resolve the biological ambiguity. We agreed to continued observation without intervention, not because we were comfortable, but because there was nothing to intervene upon. We would monitor, document, and reassess. Hospice care does not allow for experimentation. You do not try things just to see what happens. Hours passed. The movement did not stop. It did not worsen. It simply continued, as if time had stalled around it. Nurses rotated in and out, each one noting the same findings. No one wanted to be the person who missed a change. The atmosphere in the unit shifted subtly. Conversations became quieter. Laughter disappeared. People checked the room more often than necessary. I found myself thinking about how medicine teaches us to fear deterioration, but not persistence. We are trained to respond when things fall apart, not when they refuse to finish falling. As dawn approached, the building began to wake up. Day staff arrived, administrators scheduled meetings, emails were sent with careful wording. Eleanor remained where she was unchanged. I stood at the foot of the bed, watching the slow rise and fall of movement that still didn't qualify as breathing, realizing that we had crossed into territory where observation was the only tool left to us, and that every hour this continued would deepen the gap between what we were seeing and what our system was designed to handle. By mid-morning, the room no longer felt like part of the hospice unit. It felt like neutral territory. People kept coming in, standing for a few minutes, then leaving quietly. No one lingered long enough to get comfortable. That was the first sign that the system was struggling. When medicine knows what to do, movement is efficient. When it doesn't, people hover. The ethics consult happened by speakerphone, which is how these things usually go. A voice from a conference room across town asked us to summarize the situation. I described the findings, carefully sticking to the same neutral language we had been using all night. No adjectives, no interpretation, just observations. The ethicist listened without interruption, then asked a series of questions that were clearly designed to fit into a familiar framework. Was the patient legally deceased? Yes. Had all appropriate steps been followed? Yes. Was there any evidence of suffering? No. Was there any reasonable intervention that could alter the outcome? No. Each answer pushed the conversation closer to a conclusion that felt correct on paper and completely inadequate in practice. From an ethical standpoint, the voice said finally, there is no obligation to initiate treatment in a patient who meets criteria for death and has a valid DNR. No one argued with that. It was true. It just didn't help. Risk management followed. Their concerns were predictably narrow. Documentation consistency, chain of events, language used in the chart. They wanted reassurance that nothing we had done could be construed as negligence. I assured them it couldn't. The pronouncement had been appropriate. The subsequent observations had not changed that fact. What about transfer, someone asked, to where Dr. Price replied. There was a pause. Hospitals are comfortable receiving unstable patients. They are not comfortable receiving dead ones, especially dead ones who don't behave correctly. There was no admitting diagnosis that made sense. No service that would accept responsibility, no intervention to justify the move. The administrator shifted in her chair, flipping through printed policies. "We don't have a protocol for continued physiological activity after death," she said. "There's no category for this." That statement landed heavily. Systems depend on categories. Without them, everything becomes discretionary, and discretionary decisions create liability. Someone suggested calling the hospital anyway just to notify them. Another person suggested waiting. No one wanted to be the first to escalate something that didn't have a name. Meanwhile, Eleanor remained unchanged. The slow, diaphragmatic movement continued, indifferent to the growing circle of professionals trying to decide what it meant. A nurse came in to perform routine care, then paused, uncertain. "Do we continue comfort meds?" she asked. The question was simple and devastating. Comfort medications are intended for living patients experiencing distress. Eleanor was not experiencing distress in any measurable way. She was also not alive in any way that allowed us to assess comfort. Dr. Price answered carefully. "We don't increase anything," he said. "We don't withdraw anything either." That answer satisfied no one, but it was the least harmful option. The room filled briefly with quiet activity as orders were adjusted to reflect continued observation. No new treatments, no discontinuations, just maintenance. It felt like bureaucracy masquerading as care. I watched the nurses work, noting the tension in their movements. Nurses are used to ambiguity, but they are also used to action. Standing still while something unresolved unfolds is not part of their training. One of them pulled me aside in the hallway. "Are we doing something wrong?" she asked. The question caught me off guard because it cut through everything else. I thought about it carefully before answering. "No," I said, "we're doing exactly what we're supposed to do." That didn't sound convincing even to me. The longer this went on, the clearer it became that the problem wasn't medical. We had already exhausted the medical questions. The problem was structural. Our system is built on the assumption that death is an endpoint, not a process that can stall. Hospice is especially vulnerable to that assumption. It exists to manage dying, not to interrogate its boundaries. When those boundaries blur, hospice has nowhere to send the problem. By early afternoon, conversations shifted from clinical to logistical. How long could the body remain in the room? What did staffing look like if this continued overnight? What language should be used if family arrived? No one asked why it was happening anymore. That question had no productive answers. Family notification became its own dilemma. Eleanor's family had been informed of her death already. Reaching out again to say that something unusual was occurring would create confusion without benefit. There was nothing for them to decide, no choice to be made. We agreed not to contact them unless the situation changed in a way that required it. That decision felt pragmatic and deeply uncomfortable at the same time. The ethics consultant signed off with a brief note summarizing the discussion. No further action recommended. Risk management documented their review. Administration sent an email reminding staff to use consistent terminology. The system had done what it could. It had narrowed the problem down until it fit into existing structures, even if that fit was forced. I went back into Eleanor's room alone after most of the others had dispersed. The unit was quieter again, though the tension lingered like static. I stood at the bedside and watched the movement I had been watching all day. I thought about how often medicine relies on consensus to define reality. If enough qualified people agree that something is one way, it becomes that way, regardless of lingering contradictions. In this case, consensus had declared Eleanor dead, and the system moved forward accordingly. And yet, standing there, it was impossible to ignore that her body had not accepted that declaration. I checked the monitor again. The numbers flickered, then stabilized briefly before dropping away. The pattern repeated: present, gone. Present again, like something knocking on a door without ever opening it. I felt a growing sense of dislocation, as if I were standing slightly outside my own profession, watching it operate without me. This wasn't fear, it was estrangement. Hospice teaches you to be present with death, to witness it without trying to control it. What it doesn't teach you is how to respond when death refuses to complete itself. By the time evening approached, we had settled into a rhythm of observation that felt less like care and more like surveillance. Shift changes happened, notes were updated, Eleanor remained unchanged. I realized then that whatever explanation might exist for this phenomenon, it wasn't going to come from policy manuals or ethics frameworks. Those tools are designed to manage known problems, not to accommodate exceptions that don't threaten life but destabilize certainty. The system had reached its limit, and beyond that limit, there was nothing left but time bodies and the uncomfortable reality that sometimes medicine can document a situation perfectly and still have no idea what it is dealing with. I stayed late long after my shift technically ended because leaving felt like abandoning something that hadn't decided what it was yet. The unit settled into its nighttime rhythm again. Day staff cleared out, lights dimmed, the hum of the building returned to its familiar baseline. Eleanor's room sat at the end of the hall, unchanged, the door half closed the way it had been all day. I could have walked past it and no one would have stopped me. Nothing in policy required me to stay. I went in anyway. The room smelled faintly of antiseptic and clean linen. The bed rails were down. The call button lay untouched on the sheet. Eleanor's face looked peaceful, almost neutral, as if nothing unusual had been happening at all. If someone had walked in without context, they would have seen a body at rest. Not a problem. I stood near the foot of the bed and watched. The movement was still there. Slow, shallow, deliberate enough to be unmistakable if you were looking for it, easy to miss if you weren't. The timing hadn't changed since morning. 4, maybe 5 contractions a minute. No escalation, no fatigue, no resolution. I checked the monitors again, not because I expected new information, but because repetition is grounding. The pulse oximeter flickered, caught briefly, then lost the signal. When it did register, the number was low but present, as if the device itself wasn't convinced of what it was seeing. I listened with the stethoscope one more time. The sound was faint, almost imaginary, but it was consistent. Not the clean rush of air you hear in a living patient, not the silence of death either. Something in between. The nurse assigned to the overnight shift came in quietly, clipboard tucked under her arm. She had been briefed thoroughly. There was no shock on her face, just concentration. "I hear it," she said after a moment. "Every time I come in." We didn't discuss what it meant. That conversation had already gone as far as it could go. Instead, we talked logistics, vital checks, documentation frequency. What to do if the movement changed? If it stops, she asked. "Call me," I said. "If it gets stronger, call me." There were no other contingencies. She left to finish rounds, and I stayed leaning against the counter, watching Eleanor's abdomen rise and fall in that minimal, persistent way. The longer I watched, the less it felt like an anomaly, and the more it felt like a state. Not dying, not living, simply continuing. Hospice work trains you to read rooms. Families bring emotion, staff bring experience, bodies bring information. Eleanor's room brought none of the usual cues. There was no urgency, no decay, no finality, just time passing without progress. At some point, I sat down in the chair near the bed. Not because I was tired, but because standing felt performative. Sitting acknowledged that this might take a while. I rested my hands on my knees and focused on breathing slowly, careful not to sync my own breath with what I was observing. I thought about how many times I had explained dying to families, how I had described the process as gentle, predictable, something the body knows how to do once it starts. I wondered what I would say now if someone asked me to explain this. Hours passed. The unit remained quiet. Nurses came in and out, each one pausing briefly, confirming that nothing had changed. No one spoke above a whisper. Even laughter at the nurses' station sounded muted, as if the building itself was listening. Around 2 in the morning, I noticed something subtle. The intervals between movements were slightly longer, not dramatically so, just enough to register if you had been counting all night. I didn't announce it. I waited to see if the pattern would continue. It did, slowly stretching, then settling again. Still present, still steady. I checked the temperature again. Lower than before, but still not dropping the way it should have by now. I noted it in the chart, using the same careful language we had been using all day. Time behaves strangely in situations like this. Minutes stretch, hours compress. You stop thinking in terms of shifts and start thinking in terms of observation windows. Everything else fades into the background. I felt an unexpected sense of irritation, not at the situation, but at myself. Part of me wanted this to resolve cleanly one way or the other just so the rules could reassert themselves. That impulse felt selfish. The body in front of me wasn't obligated to make my job easier. I reminded myself that medicine is full of phenomena that were once unexplained, that knowledge expands unevenly, that edge cases exist whether we like them or not. None of that made the room feel less strange. The nurse returned with updated documentation and sat quietly watching with me. We didn't speak. There was nothing new to say. The sound of the HVAC system filled the silence, punctuated by the occasional distant door closing. At some point, I realized that my fear had shifted. Earlier, the uncertainty had been unsettling because it challenged my understanding. Now it was unsettling because it didn't seem to be going anywhere. Persistence is harder to tolerate than crisis. Crisis ends. Persistence lingers. I checked the chart timestamps and realized how long it had been since the pronouncement. The number felt unreal. I did the math twice to be sure. The movement had continued far beyond any reasonable window for post-mortem reflex activity. I stood up and stretched, feeling stiffness in my back. My body, at least, was behaving normally. Fatigue set in. Muscles tightened. Time left its marks. Eleanor's body seemed exempt from that progression. I leaned over the bed, again close enough to feel the faint movement under my palm. The skin was cooler now, but still not cold. There was no stiffness, no resistance. Her jaw remained relaxed, limbs pliable. I thought about how textbooks describe death as a cascade systems failing in sequence. What I was seeing felt more like a pause button pressed at an arbitrary point in that cascade, halting some processes while allowing others to drift. I checked the monitor again. The signal came and went. When it was there, it was consistent. When it disappeared, it left no trace behind. The nurse finally spoke, her voice barely above a whisper. "Do you think this is going to stop on its own?" I didn't answer right away, not because I didn't want to, but because I didn't know what an honest answer sounded like. "I think it will," I said eventually. That was the closest thing to certainty I could offer. We continued to watch the night stretching around us, the room holding its quiet vigil, the body on the bed continuing its slow, stubborn refusal to follow the timeline everyone had agreed it should obey. I noticed the change because the room felt different before anything actually changed. It wasn't visual at first. There was no sudden movement, no dramatic shift. The difference registered as absence, the way silence does when a sound you've been hearing for hours finally disappears. I realized I was counting without meaning to, tracking seconds that no longer led anywhere. I checked my watch. 3:12 a.m. I leaned closer to Eleanor's bed and watched her abdomen. The slow rise that had been there all night was gone. I waited longer than necessary, giving my brain time to argue with itself. Nothing followed. No delayed contraction, no faint release. I placed my hand on her lower ribs. Stillness. The nurse beside me didn't speak. She was watching the same place, her posture rigid, as if she didn't trust what she was seeing either. We waited together, counting silently, both of us, aware that if the movement returned, it would likely do so within the next few seconds. It didn't. I listened with the stethoscope, not expecting to hear anything new, but needing to confirm the absence just as carefully as we had confirmed the presence before. There was no sound now, no faint whisper, just the background noise of the building. I checked for a pulse again, though I already knew what I would find. Nothing. That hadn't changed. What had changed was everything else. I straightened and glanced at the nurse. She nodded once, already reaching for the chart. We had rehearsed this moment without realizing it. When the movement stopped, we knew exactly what to do. I checked Eleanor's temperature again. It had dropped noticeably since the last reading. Not gradually, sharply. The number finally made sense. Within minutes, the skin tone began to shift. Subtle at first, then more pronounced. A faint discoloration appeared in dependent areas, spreading in a way that followed gravity instead of defying it. The body was resuming the process it had paused. Rigor mortis didn't set in immediately, but the early signs were there. A slight resistance at the jaw, a firmness in the larger joints that hadn't been present before. Changes we expected finally arriving. The nurse documented quietly, her typing steady. I dictated findings the same way I had all night, neutral and precise. Cessation of diaphragmatic movement observed at 0312 hours. No spontaneous respirations noted thereafter. Progressive post-mortem changes consistent with death observed over subsequent minutes. I felt an unexpected wave of relief that had nothing to do with closure. It wasn't satisfaction, it was alignment. For the first time since this began, the body and the system were moving in the same direction again. That relief didn't last. Within the hour, the rate of change accelerated. Eleanor's body began to deteriorate faster than I had ever seen in hospice. Skin breakdown advanced rapidly. Discoloration deepened. Temperature continued to fall at a pace that suggested the delay had created a kind of biological backlog. It was as if the processes that had been suspended were now rushing to catch up. I checked the chart timestamps and did the math again, comparing the intervals since pronouncement to the extent of post-mortem change now present. The discrepancy was impossible to ignore. This was not a normal progression adjusted for environment or body mass. This was compressed. The nurse noticed it too. She didn't comment, but her hands paused briefly on the keyboard before continuing. We notified Dr. Price, who arrived quickly despite the hour. He examined Eleanor and said very little, his face set in a careful expression I had come to recognize as professional restraint. "It's progressing rapidly," he said finally. "Yes," I replied. There was nothing else to add. The observation stood on its own. By the time dawn approached, Eleanor's body looked the way it should have looked many hours earlier, in some respects worse. The room had transformed from a place of waiting to one of conclusion almost too quickly. We completed the required documentation, including an addendum noting the unusual post-mortem variants without elaboration. Language matters in records like this. You describe without theorizing. You note without explaining. Cause of death remained unchanged. Anoxic brain injury. Manner of death unchanged. Natural. The system reasserted itself with impressive efficiency. The nurse finished post-mortem care, her movements careful and respectful. The body was prepared for transfer just as it would have been if none of this had happened. To an outside observer, nothing about the final steps would have seemed unusual. I stood in the hallway as transport arrived, watching from a distance. The gurney rolled smoothly, the wheels barely making a sound. The door closed behind them, and the space Eleanor had occupied was suddenly just a room again. The unit began to wake up. Day staff arrived. Conversations resumed. Someone laughed at the nurse's station. Coffee machines hissed and sputtered back to life. Shift change reports were given careful and concise. I gave my report with deliberate restraint. Facts only. No emphasis, no speculation. The nurses listened, nodded, asked clarifying questions. None of them challenged the narrative. None of them needed to. When the meeting ended, I sat alone at the station and stared at the blank screen where Eleanor's chart had been open for hours. I closed it and opened another, then closed that one too. My hands hovered over the keyboard, unsure what to do next. I realized then that the most unsettling part of the night wasn't the movement or the numbers or the delay. It was how quickly everything moved on once the system was satisfied again. Once the body complied with expectations, the anomaly lost its urgency. There would be no review committee for this, no case conference, no broader discussion. The documentation was complete, the criteria had been met, the outcome aligned with policy. I felt a strange detachment settle in, as if the night had occurred in a pocket separate from the rest of my career. Part of me wanted to talk about it openly, to ask colleagues if they had ever seen anything similar. Another part understood instinctively why people didn't. Medicine runs on consensus. Cases that can't be resolved quietly threaten that consensus. They introduce questions without answers, and unanswered questions are dangerous in systems that depend on confidence. I left the unit later that morning, stepping out into the early light. The sky was overcast, the air cool. Everything outside the hospice looked ordinary. Traffic moved. People walked dogs. The world carried on without any awareness of what had happened inside. I sat in my car for a long moment before starting the engine, replaying the timeline in my head, checking it against itself, searching for gaps. I didn't find any. What disturbed me most was not that Eleanor's body had done something unexpected. It was that once it stopped, the system accepted the ending without hesitation, as if the hours of contradiction before it no longer mattered. I drove home exhausted, my body finally doing what Eleanor's had refused to do for so long, succumbing to fatigue. As I lay down, I realized that the certainty I used to carry into hospice work had shifted, replaced by a quieter understanding that sometimes the end arrives only after taking a detour that no one is trained to recognize. And even then, the paperwork doesn't ask where that detour led. I returned to work 2 nights later and opened the chart without thinking, my fingers moving before my mind caught up. Eleanor Vance's name was already archived, closed, finalized. The system did what systems do best. It absorbed the anomaly and moved on. There were new patients now, new trajectories, new quiet rooms waiting for predictable endings. From the outside, nothing had changed. From the inside, everything had. I moved through the unit that night the same way I always had, greeting nurses, checking orders, adjusting medications. The work itself hadn't become harder. If anything, it felt easier because I had stopped expecting it to make sense. That shift was subtle but permanent. Another patient died that week, a man in his 70s with end-stage heart failure. His death followed the script perfectly. Gradual decline, slowing breath, final stillness, post-mortem, changes right on time, no ambiguity, no questions. The nurses handled it with practiced calm. I pronounced him, documented the time, and moved on without incident. I noticed something about myself during that pronouncement. I didn't feel reassured. I felt relieved, and not in a healthy way. The relief wasn't about compassion or closure. It was about conformity. His body behaved correctly, and that felt like a small mercy. That realization unsettled me more than Eleanor's case ever had. I began paying closer attention to things I had previously dismissed as noise. Slight delays, subtle inconsistencies, charts that didn't quite line up with what I was seeing at the bedside. Most of the time there were reasonable explanations: fatigue, equipment, human error. I accepted those explanations because they worked. But now I noticed how often they were accepted because they were convenient. I spoke to colleagues, carefully testing the edges of conversations. I asked if anyone had ever seen post-mortem changes behave strangely. I framed it hypothetically, casually. Most people laughed it off or shrugged. A few paused before answering. One nurse told me quietly that she had once seen a patient who stayed warm far longer than expected. Another mentioned hearing a sound she couldn't explain during night rounds years earlier. None of them had documented it. None of them had escalated it. They all described the same response when it happened. Discomfort followed by dismissal. Hospice culture encourages acceptance. That's one of its strengths, but it also encourages silence when acceptance is the easier option. I found myself thinking about Eleanor often, not with fear, but with a kind of professional embarrassment. Not because I had done anything wrong, but because I realized how much my confidence had depended on things behaving as expected. I had trusted the system to define reality for me. The truth was, Eleanor's case didn't break the rules. It revealed their limits. Medicine teaches us to draw lines: alive, dead, treat, do not treat. Those lines are necessary. Without them, care collapses into indecision, but those lines are also abstractions. The body doesn't know where we draw them. I started sleeping poorly, not because of nightmares, but because my mind kept replaying small details: the timing of the movement, the delayed cooling, the accelerated decline at the end. None of it fit cleanly, but none of it was impossible either. It existed in the margins. Medicine prefers not to look at for too long. 6 weeks after Eleanor's death, I submitted my resignation. I cited burnout, accumulated stress, the emotional weight of end-of-life care. All of that was true enough. It was also incomplete. I didn't mention Eleanor. I didn't mention the movement or the hours of observation. I didn't mention how the system had closed ranks around something it couldn't explain. Administrators accepted my resignation without surprise. Hospice turnover is common. No one asked me to elaborate. They thanked me for my service and wished me well. The transition was efficient, almost elegant. On my final night, I walked the unit one last time. I stood outside the room Eleanor had occupied, now reassigned to another patient with a different story and a different ending, waiting patiently in the wings. The room itself held no memory of what had happened. Rooms never do. I said goodbye to the nurses. Some hugged me, others nodded quietly. No one asked why I was leaving. In medicine, departures are rarely interrogated. People assume you have your reasons, and they are usually right. Driving away from Willow Crest. For the last time, I expected to feel relief. Instead, I felt something closer to resignation in the truest sense of the word. Not giving up, but letting go of an idea I could no longer support. I still believe hospice care matters. I still believe in comfort, dignity, and presence at the end of life. What I no longer believe is that we understand death as well as we pretend to. Eleanor's body didn't come back to life. That's important. There was no miracle, no recovery, no reversal. What happened was quieter and more troubling. Her body continued in a state that didn't fit our definitions, sustained by mechanisms we don't measure because we don't know how. That realization changed the way I look at every death I witnessed before hers. I wonder how many times I interpreted deviation as error instead of information. How often I trusted patterns because they were familiar, not because they were complete. I don't regret leaving hospice. I don't regret staying as long as I did. What I regret is how confident I once was that the rules told the whole story. Sometimes late at night, I still think about the sound in Eleanor's room. Not the movement itself, but the absence that followed. The moment when everything aligned again and the system exhaled in relief. That relief now feels misplaced. Death is not just an event, it's a process. And like all processes, it has variability. We simplify it because we have to, not because it's simple. Eleanor reminded me of that in a way no textbook ever could. I no longer work in hospice. I no longer pronounce death for a living. But I carry that night with me not as a horror story, but as a correction. A reminder that certainty in medicine is often provisional and that the spaces between our definitions matter more than we like to admit. When people ask why I left, I give them the short answer. It's easier that way. The longer answer doesn't fit neatly into conversation, just as Eleanor's body didn't fit neatly into our charts. I don't think about her every day anymore. Time dulls even the sharpest experiences. But when I do, I don't feel fear. I feel respect. For the body's refusal to rush, for the reminder that endings don't always follow our schedules. And when I hear someone say that death is straightforward, that it's a clear line once you know where to look, I remember standing in that quiet hospice room, listening to something that shouldn't have been there, and realizing that sometimes the most honest thing medicine can say is that it doesn't have all the answers. I don't tell this story because it's shocking. I tell it because it changed how I understand medicine. Working in hospitals and hospice taught me to trust systems, protocols, and clear definitions. Doctors are trained to decide. Nurses are trained to observe. Together, we build order around moments that would otherwise feel unbearable. Most of the time, that system works. It has to. But cases like this remind me that the human body doesn't always cooperate with our categories. Life and death are not switches, they're processes, and sometimes those processes don't respect the timelines we depend on. That doesn't mean medicine is broken, it means it's incomplete. I think about the nurses who stood in that room with me quietly documenting something they knew didn't fit. I think about how many doctors and nurses' stories never get told because there's no safe place for uncertainty in modern healthcare. And I think about how easy it is in a hospital setting to mistake silence for understanding. The lesson I took from this wasn't fear, it was humility. Medicine works best when it accepts its limits, when doctors and nurses are allowed to say, "I don't know," without feeling like they've failed. If stories like this matter to you, real hospital experiences, honest doctors and nurses' stories that don't fit neatly into textbooks, consider subscribing to the channel. These are the kinds of cases that stay with people long after the shift ends, and they're worth talking about even when the answers aren't clear.